Good, good. Okay. I have the great pleasure of bringing to you one of my, well, good professional friends. In fact, I went to a lot of effort to befriend this man because I've been reading his scientific research. He publishes in the big five medical journals, respected all over the world. And so I ran a professional weekend in November of 2014. And I had in mind just one person I'd like to attend, even though he had to fly all the way from Copenhagen, even though I felt like he should have a first-class seat on the airplane, even though it was of great effort and some financial consequence to bring him over. It was so important to bring our next guest over because I consider him the world expert on breast cancer and mammography. And this is Breast Cancer Awareness Month, October. We're at 2022 Breast Cancer Awareness Month. And so I felt if I could impose upon my friend, Peter Gøtzsche, if I could impose upon him to come and talk to us about how he feels about breast cancer and mammography, it'd be a great service to my followers and listeners. I know you hear me talk about it. You hear my concerns that I believe it's oversold at the very least, if not harmful to women. But, that's me saying, I'm just, a country doctor here. I'm not a worldwide figure like our guest. And so I'd like to bring to you all the way from Copenhagen, Denmark, Peter Gøtzsche.
Thank you.
Peter, yeah, nice to have you again here. Did you have a good time with us back in 2014 when you came over?
Oh, yeah, that was wonderful. I came from Vancouver where I gave a talk, and then I came to your place, and then I went to Los Angeles where I got a very nice prize for what I had done to help psychiatric patients. So I gave a talk there too. About mammography screening, I came into this in 1999, 23 years ago, because in Sweden, where they started very early with mammography screening, they had not been able to see any effect in practice. Those counties that started early did not have any bigger decline in breast cancer mortality than those that started very late. So therefore, the Danish National Board of Health asked me to review the randomized trials of mammography screening, which Sweden is very proud of because most of them have been done in Sweden. And when I reviewed these trials with my statistician, we were shocked. There were so many problems with them. And one of the major problems was that cause of death was unreliable. It favored screening over no screening. There are several reasons for this, which I shall come back to. But our report, based on the randomized trials, was pretty negative, which caused a stir at the National Board of Health because we were going to introduce screening in the whole of Denmark. Then we were asked to do a Cochrane review that came to the same result. It took another year, but it took us 5 years to publish the harms of mammography screening because the Cochrane group didn't want to publish the harms. This was a major scandal in Cochrane's history. And I wrote a whole book about mammography screening where I described this scandal in detail. If you review an intervention, you must, of course, look at both benefits and harms. But the Cochrane group didn't want that, even though it was part of our protocol, which the group had itself approved and published. So it was very, very bad. And now I'll tell you a little about mammography screening. I published a paper 7 years ago where I summarized our own research and the research of others and concluded that mammography screening should be abandoned. It should be stopped because it not only doesn't work, it's actually harmful. So I will now explain why it is harmful. First of all, as every citizen understands, if screening for cancer is going to have an effect, you must find cancer in earlier stages when you screen for it, before it has metastasized, compared to if you do nothing. And what happens with mammography screening? You don't find cancers earlier. There are several studies of this, and one of them looked at tumor size. If screening is effective, the tumors should be smaller. But those that are 2 centimeters or larger, I know that you use inches in the States, it's a little less than 1 inch. They are the same in occurrence in the screen group as in the control groups. And if you look at those that are advanced, that have metastasized, then again, there is no reduction in number of cancers that have metastasized when you screen. This means that physiologically, biologically, mammography screening cannot work. So why is it that the randomized trials have claimed that they reduce breast cancer mortality by, well, the typical propaganda says 30%. Well, this is above all because to say whether a woman died from breast cancer or something else is biased. We have shown this again and again in our research based on the randomized trials. So what did we do? Sometimes the women are told that, oh yes, you did not die from breast cancer, but then they died from another cancer. And then it doesn't matter if one cancer or another is written on the death certificate if they die at the same time. So of course, we also looked at total cancer mortality, and it was exactly the same. We also looked at total mortality. It was also the same. So people don't live longer by attending screening. They absolutely don't. And these randomized trials are so biased that I did an analysis that showed that if screening has absolutely no effect, that it does not reduce the occurrence of advanced cancers, then what did my analysis show? That breast cancer mortality was reduced by 16% when it cannot work. This shows you that the bias in ascertainment of cause of death is around 16%.
Well, that's getting a little bit complicated for me. Can you let me see if I can intervene here and lay upon the discussion, my interpretation of what's going on when mammography fails is because cancer is slow growing. And by the time a mammogram finds the tumor, it's been growing, well, on average, 14 to 17 years. And at that particular point, if it's going to spread, it's already spread throughout the rest of the body. In other words, mammography is really late detection. Am I right in that interpretation?
You are absolutely right. And I had planned to come to exactly that I have made an estimation based on how quickly a cancer divides, how quickly the cells divide. And of course, this need not be constant. It could change throughout the life of a cancer. But if you assume that it is constant, then I have calculated then that when a cancer can be detected by mammography screening, the woman has harbored that cancer for about 20 years on average. So we are told that by catching cancers early, we might help women to survive, but you're absolutely correct that this is not early. Breast cancer has been there for many, many years before it can be detected on a mammogram. And it is also correct that it is likely a systemic disease very early on. So it has already metastasized when you find it. But you cannot always detect the metastases. Because how do you detect them? Well, you take out some lymph nodes and then you see if there is cancer in them. But you can have metastases elsewhere in the body that you cannot detect. Michael Baum in the UK is a breast surgeon who knows a lot about this, and he says it's very likely a systemic disease almost from the beginning. So now we start understanding why, if a breast cancer is treated, that it can come back after 5 years, 10 years, 15 years, even 18 years, one in my own family. If it grows very slowly, it takes many years before it comes back, but it usually comes back. But of course, a woman can be lucky and die from other things before it comes back. But the main point is that mammography screening cannot work based on the biology we know about. And it doesn't work if you look at the randomized trials, since total mortality and mortality from any cancer is exactly the same.
Well, let's guess that mammography is able to find that very narrow window and finds a woman who has a cancer that's still confined to the tumor before it's spread. And we save that one life. That's quite rare, isn't it? And we can counterbalance that with the fact that, our treatments take another life. Women die of surgery, they die of chemotherapy, they die of complications of radiation. So even though, the argument might be, and I think Cochrane makes that argument. By the way, Cochrane is the most respected, unbiased organization in the world.
It was.
Peter Gøtzsche
it isn't. It was. It isn't.
It was upon a time when I first started following you. It was. I mean, I praised almost everything that the Cochrane collaboration came out with. Yeah. Critically, by the way, I didn't believe all of the results that they came out with, but with your conclusion, you may save one person, but the treatments end up killing another or another, and it just balances out with no survival.
Oh yeah, I will go into that now then. That there is a very narrow window between when you can detect a cancer on a mammogram and when you can detect it clinically because you feel a lump. It is less than a year. So it is unlikely that a cancer should metastasize in this little window when it has grown for many, many years and likely is systemic out in the body already many years before. And as you say, you get nothing for free in healthcare. And when you screen for cancer, you detect cancers that are innocent, that you should not have detected, which grow so slowly that they would never have come to the woman's attention in her remaining lifetime. We know this best from prostate cancer, for example, that it follows approximately your age. So males who are about 70 years of age, about 70% of them have prostate cancer. But it doesn't matter because in the vast majority of them, it will never harm them before they die from other causes. This is why we don't screen for prostate cancer, because this is very, very harmful. The treatments are horrible, so we don't do that. In America,
excuse me, there's a lot of gender bias you're talking about here. We're talking about gender bias. We're talking about a male-dominated medical business giving men a much more honest appreciation of their trouble, which is prostate cancer, versus men taking care of women. We're talking about a gender bias here, aren't we?
Maybe we are, but the cancers are not the same. But you're right. These aggressive people that have propagated mammography screening all over the world, they are by far mostly males.
Yeah,
you're absolutely right. Even though it's a female disease.
But we give men a better break when it comes to prostate cancer. Same disease, basically breast cancer and prostate cancer. But when it comes to recommendations and honesty, that we communicate to the population, we give men a much better answer, a much more honest answer than we give women. I know I just got sidetracked there. You have okay.
No, it's very relevant what you're saying, and let me explain why women who get overdiagnosed, they run a greater risk of dying. We did a meta-analysis of overdiagnosis where we showed that it is around 50%, not 15, but 50%. So if you diagnose 3 cancers in women by screening, 1 will be overdiagnosed and innocent. But since you cannot tell which of the 3 that are innocent, you have to treat all 3 of them. And when you treat innocent cancers, harmless cancers, you often give women radiotherapy. And what does that mean? Radiotherapy increases your risk of dying from heart disease. It increases your risk of dying from lung cancer because the lungs are just there behind, and from other cancers. So this increase in deaths will nullify any possible effect there could be of mammography screening on breast cancer mortality. You alluded to this before, and now I have explained it. In Denmark, we have somewhat less overdiagnosis, perhaps 35%, but it is a huge problem. And many people who are knowledgeable, for example, the editor of the previous editor of British Medical Journal, who was a woman, when I gave a talk in Oxford about people should not go to mammography screening, she said afterwards, I know Peter's research, and people on the other side complain why our journal are not publishing their stuff. But it's not so good as what Peter publishes. And I know what he has published, so I don't go to mammography screening. That was the editor of the British Medical Journal, and I have similar stories from many well-educated women who know about my research. They believe more in that than official recommendations from the authorities.
Yeah, but I want to point out, you're not the only one that says this. I mean, there are lots of experts, including H. Gilbert Welch, who's made a lot of effort to tell women that they're being overdiagnosed. In other words,
yes,
they would have never died of breast cancer, but when you go busily looking for it, then they have to live the rest of their life as a cancer victim. They can't get health insurance. They can't get medical insurance. They can't get a job. Everybody meets them and looks at them and says, oh, breast cancer. Hi, Marge. You know, it changes their whole life by being overdiagnosed with a cancer that would have never shown up. But because you're busily looking for it with mammography, you are now diagnosed.
And there is one thing that we also need to talk about, and these are the false positives. An overdiagnosis is not a false positive. It is a diagnosis of a harmless cancer. But then we have the false positives. The more often you get a mammogram, the greater the risk that sooner or later the radiographer will say, oh, hey, there is a cancer here. And then you are called for additional investigations, maybe another mammogram, maybe a biopsy, whatever. And then most of these people, they will be told that it was a false alarm. We suspected something, but it wasn't cancer. So you are cleared, you are free. Now, one of my colleagues in Denmark has studied in detail what this does to women. It has a tremendous effect to first be told that we suspect you have cancer, and then later to be told you don't have cancer. Some women, they think, well, if they could be wrong the first time, they might be wrong the second time. So perhaps I do have cancer. So they start to worry. And he has published data that shows that 3 years after a false positive diagnosis, where the woman was told that you don't have cancer, then the level of anxiety and other psychological problems was between those who were told they had cancer and those who were never told that we suspect that you might have a cancer. So even 3 years later, they were pretty worried and anxious about this false positive diagnosis. Now, how many women are harmed by this? United States is more aggressive than any other country when it comes to cancer screening. And you screen more often, and some people get screened already when they are 40 years of age and so on. So in America, the risk of getting a false positive diagnosis by going to mammography screening for your whole life is about 50%. It's about half. So you are scaring half of the female American population if they go to screening because of a false positive. So if you start to add the pluses and minuses, including that you are harming half of the female population, you can only arrive at one result. This intervention is very harmful. It must be stopped.
Let me just get into another area of research, and you may have had some involvement in it. It's where they did serial mammograms on women. They randomized them into two groups, a control group and the intervention group. And the intervention group got mammograms every couple of years for 6 years. And the control group, they only got an initial mammogram and then one 6 years later. And what they found is those who had frequent mammograms had 22% more cancers found. And the conclusion was, and this is what I want to kind of get you off track on, the conclusion is that in this interval period of time, in those that didn't get screening, 22% of the cancers regressed or went away spontaneously. Yeah. Are you familiar with that? Can you talk about that a little bit? Because that gives some hope that this is a disease that the body cures on its own if you don't go busily looking for it.
Well, the research group I was part of have come to the same conclusion, that mathematically, we can only make numbers meet by assuming that a good deal of the overdiagnosed cancers, they would have been taken care of by the body without any intervention. They would have disappeared again. And we now know these days, when people screen so much for cancer, that it is not so uncommon that cancer disappears again. But if cancer comes and disappears without screening and you never knew it was there, then you think getting a cancer diagnosis is a death sentence, which it was 30 years ago. But nowadays, when you screen a lot for cancer, it's not a death sentence. It's very, very different. So it's important to be aware of these things. But I wonder what kind of study you were talking about, because the randomized trials I have seen, there was no screening in the control group. That was not the idea. They were just a control group.
Right, there's no screening. The ones that got the screening, they got it every 2 years in a 6-year interval. So in other words, they were busily looking for breast cancer. And in the ones that they ignored, there was a difference of 22%. There were 22% more found in the screen group than those who weren't aware of it, which means, and it should have been the same, but it needs 22%.
Now I know. This is research that my collaborator from Norway has done primarily, and which I joined him about. Now I know what you're saying.
All right.
We're not talking about randomized trials now, because in the randomized trials, you did not have a mammogram when you were randomized. But he has looked at the data in the way you describe. And this has led us to conclude that this doesn't make sense unless a lot of these cancers disappear again.
So spontaneous regression, in other words,
yes,
the cancer clears itself on its own. And if you're busily looking for it, then you find a whole bunch more cancers. And then a woman is diagnosed as having breast cancer.
Oh, yeah.
In other words, another argument to not get it done.
And I want to give the listeners the most absurd example I know about, which is that in Finland, they have taken rather young people who died from other causes, for example, traffic accidents, and then they have cut their thyroid in thin slices and looked at them under the microscope. And they found thyroid cancer in so many people that it is likely that if they had cut it in even thinner slices, they might have found thyroid cancer in everyone. So we likely have thyroid cancer or get thyroid cancer, every single one of us. But I have never heard of a single patient who died from thyroid cancer. This is very rare. And yet I saw some American celebrity. I don't know if it was a sports person or whatever it was. Oh, it was a singer. Yeah, a famous singer who was so happy that he was screened for thyroid cancer, because if he lost his voice by being operated, which is harm from the operation that can occur, he could not sing any longer. So he made propaganda for thyroid cancer screening, which is totally ludicrous. They introduced this in South Korea, but they stopped it again because the number of cases skyrocketed, because maybe we all have it. So that was really, really stupid.
Well, let's see if we can take this back to breast cancer.
I think it was Rod Stewart who made this propaganda for thyroid cancer screening.
Yeah, movie stars do a lot, as far as like Katie Couric. She was just diagnosed as breast cancer. You know, Katie Couric in our country, she's a big promoter of colonoscopy, and a very, very well-known news reporter, et cetera. And she was just diagnosed as breast cancer a couple of weeks ago. And of course, she's the head of the screening programs in the United States, or at least a big spokesperson for it. And her conclusion was that you should get more screening done, even though she's the head of screening and was diagnosed with this disease. But I just want to know, what do you think the estimate is? And I'm going to give you a figure that I know of women, say in their 40s, who don't know that they have breast cancer at all. If you carefully look, just like you looked at these thyroid cancers, you really did careful microscopic dissections, and you look for, atypic changes, early breast cancer, et cetera. How often do you think women have breast cancer? I mean, of the whole population, do you think 10%, 30%, 50% are running around with this disease and don't know they have it, and never would unless they go looking for it?
I have no idea. I didn't study these numbers.
Well, I have research that shows as many as 40% of women in their 40s have some stage of breast cancer, and it never appears. But if you look for it.
But let me tell you one thing that is really devilish. There are some early cell changes that are called carcinoma in situ.
Oh, yeah.
This means that there is cancer in the location, but it has not penetrated the basic basal membrane, and it has therefore not become invasive. So it has been discussed, why do we then call it carcinoma? Because it's not a cancer, it's just some cell changes. Now, the irony is that when you use mammography for screening, you detect a lot of people with carcinoma in situ when you start looking for it. And carcinoma in situ often disappears again. But it is devilish because it might be bilateral. And then the poor woman might lose both breasts. Instead of just let us wait and see if it doesn't disappear again, which would be the correct way of dealing with carcinoma in situ if you have nothing else than that. And this brings me to the two people.
Let me make a little comment on that, because this is really important. A lot of women are told they have carcinoma in situ, but as you say, it's really not a cancer. And you and I have been in the medical business for the same length of time. In fact, I have a few more years on you.
Yeah.
Is that we have never known what the right treatment is for carcinoma in situ. And there's still tremendous debate. So whether you should do nothing, whether you should have the area taken out, whether you should add radiation, whether you should add hormone therapy, chemotherapy, we have no idea how to treat it. And yet, if you get this disease, or this finding on pathology, you are a cancer victim. These women believe they have fatal cancer.
Yeah,
the other thing I wanted to mention is that, again, I've been interested in this subject a long time, is I can show you research that would cause you to think about breast tissue as one organ, not two separate organs. And that women who have breast cancer in one breast, if you look hard enough, you'll always find cancer in the opposite breast, because it's all breast tissue. It's not separate, like the right one gets it and the left one doesn't. It's all affected by the things that cause breast cancer, all the tissue.
That's the idea of it being a systemic disease early on, but let's not call carcinoma in situ a disease, because it's not a disease. It's just some cell changes. Yeah, it's just some cell changes. People are fine. So now let me come to the two big lies about mammography screening. It has been sold to the public with two simple messages. It saves lives. We know this isn't true. And it saves breasts, because by detecting it early, you can do a minor operation instead of removing the whole breast. Now, the big irony, which we were the first to show, I think, in our review so many years ago, is that because of the overdiagnosis and because carcinoma in situ is often diffusely spread in the breast, then many women lose a whole breast if you detect carcinoma in situ. So the number of mastectomies, which means removal of breasts, went up when you started screening. We have shown this in Denmark also, not only in the randomized trials, but we showed it in Denmark, where we only had screening in 20% of the country for 17 years. This was because of my review that the politicians in the rest of the country, they said, oh, well, we have big respect for the Danish National Board of Health, but we also have respect for the Nordic Cochrane Center headed by me. And then they would not introduce mammography screening. So we had a wonderful control group. And when we looked at that, we saw the same. About 20% more mastectomies in the screened areas as in the unscreened areas. Now, is this only because you detect the cancer earlier, so there must be more mastectomies in the beginning that are compensated later on, which means you have a mountain of breasts that are removed in the beginning, and then you need a valley of the same size with fewer breasts being removed as in the control areas? That never happened. So we have shown also in Denmark, using real data, that yes, more women will lose a breast when they go to screening and they won't live longer. It's a bit like for prostate cancer, where I invented this joke. Someone was stupid enough to get screened for prostate cancer, and then he's going to get operated upon, and he asked his doctor, "Doctor, can you promise me that I will live longer if you remove my prostate?" "No, but I can promise you it will feel longer, because you will be unable to have sex and you might become urine incontinent."
Let me ask you. You had your wife is about your age, as I remember. I only had a casual reading of her. What do you tell her about mammography screening? And you have a daughter that's getting into the age group where she'll have to get advice too. Because they have friends who are getting their mammograms, believe in them, so on. How do you counter this?
Well,
and people so close to you.
Well, my wife is not my age, but she has passed 60 years of age now. And she couldn't dream of going to mammography screening because she knows about my research.
All right. She
And
believes in you, just like Mary believes in me. But I mean,
yeah,
is there an explanation you could give her? That's just some simple words. Look, wife, I know this about mammography. Like I would push any woman who asked me with the fact that this is a disease that's on average 14 to 17 years old by the time a mammogram finds it. Anyway, I just wondered if you had some key words for your wife.
no, not 40 to 60 years, not that many years, but it has been
No, it's 14 to 17 years.
Oh yeah. I heard you wrongly. Yeah, of course. Now, my wife doesn't reject mammography screening because she believes in me. She actually also knows about my research, which is far more important because she's also a researcher, She is a doctor and a researcher. And she got angry when she was called for mammography screening the first time. Because she said, what the hell? They have even booked a time for me for an investigation I never asked for. So now they tell me I should call them to cancel the appointment. She refused to do that because she never asked for an appointment. So they were looking for her in vain. She just stayed away.
Well, I know this is a little bit out of your field as a researcher, but do you have any words of wisdom as far as preventing breast cancer that you might give women that are listening? I mean, how do you get this disease? What would you do to prevent it? Do you have any thoughts on that? You've been at least peripherally involved in that part of the disease.
Well, you're right. It's not my line of research, what causes breast cancer, but what we do know is that we use so many chemicals nowadays, and some of them have hormonal effects. And for example, there was this alarm that alligators in Florida, their penises, they were getting smaller, I think. We do know that some chemical substances increase the risk of getting breast cancer. We know that very well.
I took you out of your area of expertise for a minute. Are there any final words of wisdom as far as mammography you'd like to offer my listening audience?
Oh yeah. Oh yes, there is one very, very important thing. Some people have asked me, even recently, what should I tell my doctor? He is so, or she is so eager convincing me I must have regular mammograms. I'm crazy if I don't. What should I tell my doctor? That's very easy. It's my body. It's not yours. You are just here to service me. I make up my decision.
Do you know what I tell women?
No.
Because they get threatened all the time. They'll call them up at home after the office visit. They'll really belittle them. I tell them, look, there's a book. It's very scientific out there. All you need to do is buy this book. It's for sale on Amazon. It's called Mammography, Truth, Lies, and Controversy by Peter Gøtzsche. Buy that book, throw it on their desk and say, Doc, if you read this book, and you can come back to me and tell me that I should get a mammogram, I'll do it, but I bet you won't. That's what I tell them.
Yeah, they can also read a short article, the one I published in 2015 in Journal of Royal Society of Medicine, a very nice UK journal, where I summarize the most important reasons why you should not go to screening.
I have that article. In fact, it's open access, so it's available to anybody to read, and it's a great article. But again, it gets a little complicated for the average woman out there to read and understand. Whereas you could take the article and put this article on your doctor's desk and say, all right, I know you believe this is to my betterment, but the science contradicts what you have to say, and here's the science. Here's the book, Mammography, Truth, Lies, and Controversy. Here's the paper by Peter Gøtzsche.
Yeah.
So, it's up to you to present to me. I'm the customer, just like you were trying to say. I'm the customer.
Exactly.
Show me that it works.
Exactly. Yeah. That would be the right attitude.
Yeah. Well, I want to thank you very much for the time you spent sharing with me. It's been going on since 2014. We've been professionally associated for almost 8 years, and
Yeah.
I respect your work, and I I understand how much fun you have being a controversial figure in the world. You are a worldwide figure. You're known in every scientific community because of the work you've done. And you got
But
one fan out here, Peter. You got one great fan. I still
well,
talk about you all the time.
well, I share it because I'm a fan of you, because you are incredibly good in communicating. When I visited you 8 years ago, I gave 3 interviews, one about mammography screening and one about organized crime in the drug industry. This video is still being seen by many people. It has been seen by almost 500,000 people. This 7-minute interview you organized 8 years ago. This is amazing. And
It got you in a bit of trouble too, didn't it?
no, and some people have translated it with subtitles in a number of different languages. Oh yeah.
Well, my goal is to bring the truth to people,
Yeah.
and having experts like you that I can bring to their attention is really important. So I want to thank you very much for the time you spent with me, and I look forward to more time we can spend together.